We've had a fantastic morning, some amazing oral presentations, and I think the e-posters were fantastic. We actually had a record turnout of the e-posters, and there was a tremendous amount of vibrancy related to those presentations. So we're going to segue to one of the highlights of our day, which is the Gordon Murray lecture. And the theme of this lecture really is reflective around the way we've positioned a Gallie Day this year around the impact of global surgery on human health. So it's really our honor to welcome Professor John Meara here to Toronto as our 2024 Gordon Murray lecturer. And when we were thinking about the theme of global surgery and the impact on human health, it immediately became apparent to us that arguably one of the most important figures in this field is in fact Professor John Meara, and we're really honored that he is with us today. So John is the founder and director emeritus of the program in global surgery and social change at Harvard University, where he holds a number of appointments in the Department of Global Health and Social Medicine, as well as a professor in the Department of Surgery. And he's the surgeon-in-chief for plastic surgery at the Boston Children's Hospital, where he also chairs the medical executive committee. So this is a snapshot of one of the key kind of signature articles from this famous issue in The Lancet that I'm sure Professor Meara will talk about extensively in his talk. But if you're not familiar with this, I think really that every surgeon globally should be aware of this. And this was really a landmark effort which highlighted the global significance of surgery. And remarkably, in international planning, it was felt that surgery was really something that just was of relevance in high-income countries, maybe selected middle-income countries was really not all that important. And surgery has, to a large extent, been neglected in terms of social planning. And as was really highlighted through this, this effort that Dr. Meara was critically involved with, the Lancet Commission in Global Surgery, really highlighted that one of the largest gaps in the equitable delivery of healthcare around the world is a lack of access to surgery. And this is really quite remarkable. So we will hear about this, and I think this has really kind of been a landmark effort. And then this subsequently spawned a major program in global surgery at Harvard, the creation of the Paul Farmer Fellowship Program, and I'm sure we'll hear quite a bit about Professor Farmer's legacy as well in Dr. Meara's talk. So without further ado, it's our honor, John, to welcome you to deliver your keynote lecture on the Peace of Westphalia, Global Surgery and Social Change. Thank you.
Thank you, sir. Michael, thank you very much, and Carol, thank you for inviting me. It's an honor to be here. Carol and I were just chatting. She looked up at this picture and said, "Wow, did you do that?" Yeah, it took me 6 months. It's an oil on canvas. No, I can't paint. But in reality, actually, this is a ChatGPT image. So I asked it to create an image that represented the Peace of Westphalia, global surgery, and social change. Those are the only prompts that I gave it, and this is what it came up with. And so I'll talk about that a little bit more. Now, I will tell you, It's such an honor to be here. I made the mistake of looking at the prior speakers, and it's a little anxiety-provoking to see who's spoken before. So I'm really honored and humbled to be here. This is the outline that I'm going to talk about. So a little introduction about me, just to give you an idea of where I come from and what my perspective is. And then I'll get into the Peace of Westphalia, and I'll talk a little bit about Paul Farmer. One's kind of a nation-state approach, and Paul was the ultimate humanist, and I'll talk about his approach and where he came from, not geographically, but why he was the person that he was. And then I'm going to get into the Lancet Commission, and I see Anna Dare here. We've been colleagues and friends for over a decade. She was involved from the very beginning of the Lancet Commission, and Joanna Reisel, I don't know if she was on call last night. I think she's in theater, but she was also involved. And then at the end, with the last few slides, given the perspective that I have over the last decade or more, I want to talk about where I think global surgery needs to go, what it needs to focus on, what are the major issues in the world right now that we need to pay attention to. So I'm the product of the kind of typical American melting pot. My father's parents, or not parents, but his ancestors were from Germany and Ireland, but that was in the 1850s. I didn't know those folks. His grandparents were born in the U.S., but on my mom's side, her parents were from Malta, and I mean from Malta, like right off the boat in the about 1920s. And I got to know them fairly well. They had gone to Detroit, and there was a large Maltese community there, and then kind of towards the end of their life, they moved to East Lansing, which is where I was. And, you know, for example, I had a perspective on the immigrant experience in the sense that my grandfather, I remember him telling me that it was his father who told him, you know, go to America, there's nothing here for you in Malta. And so he moved, and his mother never forgave his father because he never saw his mother again. She never saw her son. He left when he was 16, he lied on his paperwork, said he was 18, and came to the US and moved to Detroit. So that's my background. And then similarly, as is common in the US, I moved around for my education. My undergrad was at the University of Notre Dame in Indiana. You may not have heard of it. If you have, it's probably for its football team. And then I went to Michigan, that also has a football team, but I'm not a big Michigan football fan. I went to Penn for dental school. I went to Michigan for med school and then Penn for dental school. I don't even know if Penn has a football team. And then I went to Boston, and that's where I did my surgical training. And so after that, I was lucky enough to go to the Royal Children's in Melbourne. My mentor there was Tony Holmes. He was a fantastic mentor in pediatric plastic surgery and craniofacial. And then I was lucky enough to get my first job at Children's Hospital Los Angeles. And I was there for about 3 years with John Reinisch, who was also fantastic. I've been lucky throughout my whole career to have fantastic mentors. And then Tony called me up. We thought we were going to stay in Los Angeles. Tony called me up and said, hey, I want to step down as chief. Would you come back? So I came back to the Royal Children's, and I had an opportunity to go to the Melbourne Business School. So enough about me and my background. In 2006, again, much to my surprise, and serendipity, I think, plays a lot in all of our lives and in our careers, had the opportunity to come back to Boston again. And so it's one of the few places that I would have left what we had in Australia, because it was a wonderful city, wonderful hospital. The people were fantastic, just loved it. More importantly, this is my family. So this is back in Australia years ago, and that's my wife, Anne. We met at Notre Dame, and it was very romantic. We were in differential equations class together. I mean, can you picture it? Like, we would slide second-order differential equations to each other. It was these are our two daughters and our son. They went to Loretto Mandeville Hall with these cute little uniforms. And then this is later, actually, when we came back to North America. This is in Quebec City, right before Christmas. And you can see from the hats, the Notre Dame hats, we start the indoctrination program very early in my family. All of them went there. I went there, my wife, my father, my brother, my cousins. So a few people have gone there. And this is a couple years ago. These are my kids now. Emily's in med school at UMass. Ellie's in Honduras and applying for medical school. She's worked there for a year. And Nick is in his third year at Notre Dame, and he's applying for maybe dental school, maybe med school. He's not 100% sure. So what that means in American terms is that I still have a lot of tuition left. Part two to my talk. Sovereign Obligation, Liberation Theology, and Paul Farmer. And this also was a chat GPT image. I just put in those terms and asked it to make an image for me. So I'll talk about this just briefly. So the Peace of Westphalia was what brought the 30 Years' War to an end in Europe, and that was in 1648. And that was a war in the Holy Roman Empire between the Catholic princes and the Protestant princes. And the Treaty of Munster was a treaty with the Catholic princes, and the Treaty of Osnabrück was with the Protestant princes. And the important thing that came out of that was our modern day conception of sovereignty and sovereign autonomy. And so when you think about that, what are the implications for that in our world today, and how does that affect healthcare? And when you talk about how did Europe in particular, how did they run with sovereignty, and what are the implications for their colonial expansion, and how did that affect colonial healthcare? We're still talking about an anti-colonial approach to healthcare. A lot of this was a pretext to how Europe expanded and what its philosophy was. Now, the reason I'm talking about that is in late 2016, early 2017, I stumbled across this article by Richard Haass. He is the President Emeritus of the Council on Foreign Relations, and I would say in the post-Cold War era, he's probably one of the half a dozen really truly big thinkers in global politics and global affairs. And so whenever he writes something, it's worth reading. And he mentioned this post-Westphalian concept of sovereign autonomy. And the thesis for his article was that in the 21st century, that's no longer really an operative concept, that we need to think about obligation and sovereign obligation. And I thought that was odd and interesting, and I was glad he did that, because people don't talk about obligation and responsibility enough, I think. And in his article, he talked about trade, and he talked about military, and he talked about the internet, and he had one paragraph on healthcare. And he talked about the fact that in health, in human health, this fierce sovereignty bordering on nationalism, that was not the answer for global health. And so I actually emailed him, and I said, I'm fascinated by your theory, and I told him some of the things I was thinking about, and surprisingly, he emailed me back and was very supportive. So later that year, Brian Till, who was one of our research students in the program in global surgery with us, we wrote an article that kind of expanded on his concept of sovereign obligation. And we made 3 points. The first is that health equity and social justice can only be achieved through a spirit of sovereign obligation, that countries had to work together. Second was that global health security can only be achieved by really holistic health system strengthening, that the vertical approach was not going to work. And third, that this concept of national pandemic preparedness, remember we were coming off Ebola and people were talking about pandemic preparedness, that this was necessary but not sufficient. And we said that transnational cooperation would be essential for the next pandemic. And this was in 2017. So we know what happened 3 years later. And I think that was well borne out, that spirit of transnational cooperation probably was not there as much as we would have wanted it. And so Socrates and Richard Haass were several thousand years apart, but I think Socrates would have appreciated Richard Haass's article on the concept of sovereign obligation. So that's at one end of the spectrum, looking at sovereignty and a national approach. But I want to go to the other end of the spectrum now and talk about Paul Farmer, because he was kind of the ultimate humanist. And to Paul, the human being in front of him was the most important thing. And some of you in the audience may have known him, and if you did, he would occasionally send you an email. I'd get an email, hey Johnny, I got this patient in Haiti, and there are only 2 people in the world that call me Johnny, Paul and my aunt, and I don't know why either of them do, but if the heading said, hey Johnny, I knew it was either Paul or Aunt Linda. So to him, the patient was it. He didn't think about sovereign autonomy. He didn't think about nation states. He thought about people. And this is one of my favorite quotes of his. The idea that some lives matter less is the root of all that's wrong with the world, and that really gives you an idea of his thinking. But I want to dive into Paul a little bit in terms of where he came from and why he thought like that, because I think it's important to understand. If you've looked at Partners in Health website, or if you've read any of his books, some of the concepts that he talks about, you might wonder, where does that come from? Accompaniment, pragmatic solidarity, things like that. Where does all that come from? It actually comes from liberation theology. So in the 50s, 60s, and 70s in Latin America, this philosophy emerged. And Gustavo Gutierrez, he was a priest at that time, and he's called the father of liberation theology. And he called for economic, political, and social justice in the face of what he saw were the travesties of both the Catholic Church in Latin America and the governments in Latin America. He called for poverty alleviation and what's called a preferential option for the poor. If you look at Partners in Health's website right now, you will see preferential option for the poor all over their website. He talked about pragmatic solidarity. And what he meant is that it's not enough to pray for the poor. They don't necessarily, that's not necessarily going to help the poor. It has to be a practical approach to helping the poor. And that practical approach was what he called, and what came out of liberation theology, was accompaniment. And if you knew Paul, he could hardly get through a sentence without talking about accompaniment, because that was really part of his ethos. And what accompaniment meant to him was working with people over a long time, long-term collaboration, not just dropping in for a day or a week, but working over decades, if not more. And interestingly enough, Father Gutierrez and Paul Farmer became very good friends. I think Paul considered him one of his principal mentors, and they wrote a book together. And this is the book they wrote together, In the Company of the Poor. And ironically enough, the launch of that book was at my university in Notre Dame. So I went and I managed to get a picture with Father Gutierrez. And during the book launch, you could tell that they had such a great relationship, and they really knew and respected each other. And for those of you who knew Paul, he would say funny things sometimes, and he was talking about Father Gutierrez and what an icon he was in this field. And you know, Father Gutierrez was only about this tall, and he called him the Yoda of liberation theology. This is Paul's quote on accompaniment, and I think it really summarizes it. So, to accompany someone, he said, is to go somewhere with him or her, to break bread together, to be present on a journey with a beginning and an end. There's an element of mystery and openness. I'll share your fate for a while, and by a while, I don't mean a little while. Accompany is much more often about sticking with a task until it's deemed completed by the person being accompanied rather than by the accompanitor. Another thing that Paul talked about is the fact that all the structures in the world right now were not created by some divine entity. God did not create our healthcare structures. He or she did not create our economic structures. And Paul used to say that all the time. And so when you think back about from pre-civilization to now our organized or maybe disorganized healthcare systems, Paul always made a point to say, we did this, we structured it this way. And so he was always calling for things to be restructured, that we had the ability to achieve this, but it would require undoing and restructuring some of the things that we had done historically. So think about all of this as we start to talk about global surgery and what happened in the Lancet Commission, which is what I'll embark on now. So this, again, I asked ChatGPT to make some images related to global surgery and social change, and I don't know why, but it cranked out 9 of them in rapid succession, and these are the 9. It's really interesting to take a look at those and try to figure out what was it thinking? Where do those images come from? This was my first trip to Haiti with Paul, and this is what I saw. So this is the infrastructure in the country. This is in maybe '07. This is where they were storing food. This is up in Conge. Conge is the hospital that Paul built. And on the other side of this wall is the hospital. All right, and so this is what I saw when I first got there. And I'll tell you about one of the first patients that I saw there. This is Dumanel. And I talk about the role of serendipity and charity in healthcare. So Dumanel has an encephalocele, and I knew that couldn't be treated there. And so we brought him up to Boston. We have a free care budget at Boston Children's. And with Mark Proctor, the neurosurgeon that I work with, we repaired this. Left is pre-op, right is post-op. And here he is right before he went home. He benefited from a little bit of luck in the sense that I was there on a weekend that he happened to come there, and charity in the sense that I am fortunate to work at a hospital that is willing to do that and carve out a free care budget. And I remember being happy that I worked at a place like Boston Children's, and I still am. But there's a second case that really flipped the light switch for me. So this is Dominic. Has somewhat of a similar craniofacial problem. This is called a Tessier facial cleft. And again, I went to the operating room with Mark Proctor, and we took care of him. There he is post-op. There he is with his dad, pre-op, and there post-op he's with his dog. And this was the case where I remember thinking, you know what? Dominic didn't depend on luck or charity. He was from Wisconsin, and his father is a judge in Wisconsin, and his father had the information capabilities to find us in Boston. He could travel to Boston. He had health care insurance. And this is where I remember thinking, you know, luck is not a great strategy for healthcare. And charity is not the solution. Not that charity's bad, and I think charity's wonderful, and we should be doing charitable things, but it's not enough. It's one of those things that's necessary but not sufficient. And that is where my real interest in systems was born. Because you realize that to deliver surgery requires systems. It's a little different than immunizations. With immunizations, if you think about the supply chain and the delivery, it's infinitely easier than when you think about the incredibly complex supply chain and the training and the multiple individuals that go into delivering a surgical product, if you will. It's very different than immunizations. Now, the other thing I'll say about systems is it's a little bit like this picture. You've probably all seen this before, the elephant, and there's only one person, one person sees the tail and someone else sees this and they think it's something else. And in healthcare, it's a little bit like that because the primary care folks, they think everything's about primary care. And infectious disease, everything's about infectious diseases. And actually, last night at dinner, we were talking about this. It's led to a vertical approach. Everybody thinks their thing is the most important. Surgery, we think that's most important. Anesthesia, they're the most important. Oh, my quiz for today. How did I know that was the anesthesiologist? She's trying to nasally intubate the elephant. So you need to step back and realize that you're dealing with an elephant, and it's not just your little piece of the puzzle. So I'm going to take you through a very, very recent evolution of global surgery, and it's not complete, and I say that because you can't possibly in a few minutes talk about all the things that have happened in global surgery, and it is a disservice to say that I could, but there are a couple things that I think are important. If you go back to 1980, this is when Halfdan Mahler, at this point he was the Director General of the WHO, and he's the first global health leader who linked access to surgery and social justice and equity. And that's a big statement, for a world leader like this to say that this is a social justice issue. He said, the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity. I think that was somewhat of a turning point. 1980. So what happened in public policy? Well, for 28 years, not a lot changed in public policy. Not a lot changed at the WHO. There were still no documents, no resolutions in the WHO that mentioned surgery per se. And then this article came out by Paul Farmer and Jim Kim. I'm sorry it's so small, I should have blown it up. It said, the neglected stepchild of global health. And we were laughing about this last night. You cannot go to a global surgery meeting now without someone talking about global surgery being the neglected stepchild of global health. I don't know what it was, if it was the visual metaphor that was so powerful. I think part of it was the fact that you had two extremely well-known infectious disease leaders who were advocating for surgery. I think that was part of it. Whatever the case was, this began a process of slow traction, and this was in '08. And I say that because several years later, in 2015, so we're talking several years later, 3 things happened that were pivotal. One, the World Bank published its 9-volume series, Disease Control Priorities, and the first volume was on surgery. And to tell you the backstory, they had not planned on the first volume being surgical, and I was talking to the editors, and they said, but we had no choice because the surgeons and the anesthesiologists, they got us the stuff first. No one else would send in their chapters, but the surgeons and anesthesiologists sent in their chapters. So it had to be first. The Lancet Commission, which I'm now going to spend some time telling you about, and Anna and Joanna actually were part of the core writing team, and honestly probably represent about 50% of the Lancet Commission. So they played an enormous role in this commission. And then the other thing, which I alluded to, WHO resolutions. Every year there's a meeting called the World Health Assembly, and that's where nation states, sovereign states, come together in Geneva to the World Health Assembly. That's the governing body for the WHO. So even the WHO is structured in a post-Westphalian structure. It's nation states, autonomous nation states coming together. The UN is a construct of a post-Westphalian governmental organization, all right? But at any rate, I said that there was no mention of surgery in the WHO. In 2015, this was the resolution that was passed. So all the nation states come together at WHA, and they pass resolutions like a legislative body. And so this is the first time that the WHO had ever said that emergency and essential surgical care and anesthesia is a component of universal health coverage. First time that WHO had said surgery and anesthesia are really kind of part of healthcare, which is striking that that's the first time. So the Lancet Commission. I have to give a tremendous amount of credit to Richard Horton. He's been a visionary editor. He started this process of the Lancet having commissions. Every year or so, he would call for a commission on something of public health importance. And I think somewhat because of Paul and Jim Kim's influence, not just that article, but their influence behind the scenes, I think that's what got his attention. And so he called a small group of us together, and he gave us our marching orders, which were, I want this commission to cover the status quo. I want a few key messages, not 20, but 5 or 6. I want a few recommendations, not 20. And both he and Jim Kim actually said, we need indicators and metrics. There's no data in global surgery right now. There's nothing to track. And he said, you need to address inequities, and we want this to precipitate ongoing change and improvement in global health. And so this was our first meeting in January of 2014. You can see Anna Dare right there. And then this is in Sierra Leone, maybe 6 months later. And then this is in Boston at the actual launch in Boston in 2015. And what started with just a small group of us, and with Lars Hagander from Lund and Andy Leather from King's College, and that small group that you saw, ended up with hundreds of people in over 110 countries, ended up with publications in seven different journals around this. So there was the main publication in the Lancet, but then we had so many people contributing that we had to find other outlets for all the articles. I also always am quick to credit Jim Kim. By this point, he was president of the World Bank, and he did a lot behind the scenes, and then he also did things in front of the scenes. And I'll just show you a quick clip of something that he did for us.
Thanks so much, John. Greetings to everyone, and sorry that I can't be with you in person. Congratulations especially to the Lancet on the release of Global Surgery 2030. Today, an astonishing 5 billion people cannot get safe, affordable surgical and anesthesia care.
I'll stop there. It goes on for several minutes, but for the sake of time, I'll stop. Notice that he said 5 billion people don't have access to surgical care. All right, we're going to see where that came from and why that was introduced. So this is what we did with the commission. First thing that I'm glad we did is we defined a clear vision. Universal access to safe, affordable surgical and anesthesia care when needed. You have no idea how many hours of wordsmithing and wrangling that short phrase took. We came up with 5 key messages, 6 indicators, and then I'll tell you the backstory to this National Surgical Obstetric and Anesthesia Plan, because it's interesting how it came about. So the key messages. You heard Jim Kim say 5 billion people lack access to surgical care. I'll talk about that in a bit more. So we had an access message. We had one about how many more procedures need to be done. What patients face financial ruin because they're seeking surgery? They need something life-saving, but they just don't have the money. We had ministers of health during the process who said, look, we get the equity argument and we're all on board with that, but I need to go across the hall and talk to my finance minister. So we're going to need some economic arguments. And so we had a team that was working specifically on this. And the other thing I'll mention is that every key message and finding ended up spinning out its own research group. So all these things had a group of people that were working behind the scenes on that specific thing, and it all came together at the end because Anna and Joanna and Nicole, they were putting all this together. But all these things had a group behind them. Okay, and then this was a quote from Jim Kim, actually, in one of the addresses that he gave to us, and I think this is important because again, you have the president of the World Bank saying that surgery is part of healthcare. It seems really simple. Of course surgery is part of healthcare, but to have the president of the World Bank say that, and it's also an allusion to the integral nature of healthcare, and that it shouldn't just be a vertical approach. So 5 billion people. You've heard that before. Many of you have heard that. How did this come about? Well, 5 or maybe even 10 years before the Lancet Commission, Atul Gawande had written a paper that 2 billion people don't have access to surgery. And Paul took particular exception to that. He said, look, I've been all over. There's no possible way that it's only 2 billion people that don't have access to surgery. He said that's, and he had a more colorful statement than that, which I can't share with you. And so that spun out a group that was working on that message, all right? And so what they did, and I won't go through all the gyrations of it, but what they said to themselves is, okay, what does it take for a patient to get to surgery? And when Atul Gawande had done his study, he had talked just about safety, and he had looked at what percentage of hospitals have a pulse ox, and he had used that kind of as the metric for, and that this group said, well, wait a minute, that there are many things that have to occur for a patient to have access, and I look at it kind of like a patient jumping through hoops. So can they get there on time? That's the first hoop. Are they 10 minutes or are they 10 hours away from, surgery? And if they have, hemorrhaging, they can't wait for 10 hours. What if they can get there on time? Do they arrive at a facility that has the capacity to do what needs to be done? So that's the second hoop. Is it safe? So part of what Atul was saying is true. You want a safe facility. And then this is what knocks most people out is the affordability. Right? So that was one way of looking at access. The other thing we did in the commission is we borrowed something from the OB world in terms of how do you look at how patients get access. And there's something called the 3 delays from the OB community in terms of seeking care, reaching care, and receiving care. So do patients actually decide to seek care? Some don't. Can they reach care? Some can't. Once they get there, can they receive care? And some can't. And we looked at this. Here's seeking care, getting to care, and can they receive care once they get there? And this is another research project that came out of the commission. We looked at what's called the 3rd delay. So what causes delays in receiving care, particularly at a district level hospital? And so we had another group that worked with the WHO and looked at their district hospital level data and asked the question, are there procedures that are an indicator of a district hospital that can function like a real district hospital, that can do a broader array of procedures? So is there some way, because ministers of health were saying, what do I need to do to this district hospital? What do I need to do to that district hospital? And they wanted something tangible. And what we found is that Hospitals that could do these types of procedures, they had a capacity to be able to do more things. They behaved like a, quote, real hospital, and we called these the bellwether procedures. These were an indicator of a district-level hospital that could do a broader range of things and had the capability to deliver surgery. And it's because of the economies of scope. Paul Farmer used to talk about staff, stuff, space, and systems. When you have a district hospital that's doing this, in general, it has the staff, stuff, space, and systems to do a broader range of surgical procedures. And it helped ministers of health because they could look at a district hospital and say, oh, okay, I see. Well, gosh, the only thing we're doing at this hospital is C-sections. So I see we need to expand and bring in different supply chain, different people. When you add all of those things that I've been talking about, the question then is, what percentage of the people have access to surgical care? And in the dark red, these are the places where 90, 95, 96, 97% of the people don't really have true access to surgical care, the kind of access that you and I have right now. All right. How many more procedures are needed? At that point, there were about 250 million procedures per year performed in the world, and we, again, another group, did some modeling work to show that 143 million procedures were needed. Now, it's not the same in every country because, interestingly enough, and no surprise, the poorest third of the world's population only receives 6% of the procedures in the world. So it's a distribution issue. So let's talk about procedures for a minute. Well, to perform procedures, you need providers. And one of the questions that was asked of us in the commission is, okay, I'm in Botswana, how many providers do I need? How many surgeons, obstetricians, anesthesiologists? What's the normative number? All right, and so what we did is we collected data and we compared it to different metrics that were available, different health outcome metrics that were available with the World Bank. Now, I'm always quick to say, this doesn't prove causation, and by no means do I mean that Y is a function of X. So merely cranking out more healthcare workers is not going to make healthcare outcomes better, but it paints a picture of healthcare ecosystems and what they look like. And you find that below 20 surgeons, anesthesiologists, and obstetricians per 100,000, those healthcare ecosystems, they look different, they function differently for many reasons. What you see is there's a transition zone between about 20 and 40, and those countries, they're just different. Now, as I said, it's not just the surgical workers, but it's the whole ecosystem, the whole surgical ecosystem that's different. So it's somewhat of an indicator. If you can grow your healthcare ecosystem to be able to properly support roughly 20 to 40 of these folks per 100,000, that means something. And more is not always better. More is not always better. This is the United States way out here, all right? Our health outcomes, and you can look across many, many health outcomes, are not the best in the world by any stretch of the imagination. So more is not better. And the same with surgical volume. People ask the question, how much is too much? What do we need? And so we did the same thing just to, again, paint a picture of what the world looks like. And what we found, again, is that there was an interesting transition at about 5,000 cases per 100,000. Healthcare ecosystems started to look differently. And once again, the US, which is way out here, doing, 25, 26,000 cases per 100,000 per year, doesn't necessarily have better outcomes than the rest of the world. Across all, you can look at many different health outcomes here. So this was just a way of coming up with some normative data in terms of what the world looks like. Catastrophic expense. 81 million people are pushed into poverty, basically, for seeking surgery. And that doesn't even include the people who don't they're the first delay folks who don't seek care, that doesn't even include them. This is just the people who get all the way to the hospital and have to pay for it. No surprise as to why it is. About half the world's population lives on basically the cost of a cappuccino or a latte. So if fixing the femur fracture is $400, that's a lot of lattes. That's just unaffordable. All right, so that's the economics. Paying at the point of care is highly problematic. And this is that investment key message that I mentioned. So we had another group that was doing modeling, looking at what would it cost to bring low and middle income countries kind of up to a middle or upper middle income level. What would that cost be between 2015 and 2030? But then what's the economic return? So when you have an 18-year-old with a femur fracture and you don't fix it and they're knocked out of the economy for 40, 50, 60 years, what does that do to your economy? And there was $350 billion in cost, about $12 trillion in economic benefit. The commission, right before ours, was the Commission on Investing in Health. Larry Summers led that. And he found things very similar, that we need to talk about costs in healthcare, not as a cost, but as an investment. You're investing in health, you're investing in the economy, you're investing in the people and society. And then this was really, as I said, Jim Kim's quote that alluded to the integral nature of healthcare and the health system's benefit. The second thing that we did was we had been asked to come up with indicators, and we did. So one was an access indicator. What percentage of the population has access within 2 hours to a facility that can provide those bellwether procedures? And we borrowed the 2 hours again from the OB literature that felt that 2 hours was a critical time point. What's your workforce? Countries at that point did not really even know how many trained surgeons, anesthesiologists, and obstetricians they had. How can you run a business if you don't even know, metaphorically, who your employees are and how many you have? Surgical volume. Again, no business would run a business and not have any idea of what product you're producing every year. So just knowing what are we doing, and where is it on that? We threw out the number 5,000. Some countries are at 200 per 100,000. The U.S. is at 26,000 per 100,000. So you can argue about whether 5,000 is the right number, and I'm happy to agree with you. It might be 4,000, it might be 6,000, but it's not 200, and it's not 26,000, okay? Perioperative mortality, the crudest indicator of quality. How many people are dying? Another thing that was not routinely known. And then we had two of these financial indicators. I think now most people are talking about just having one, and I think that's reasonable. I think really we need to pay attention to 5 different indicators. There's an impoverishment indicator, mortality, volume, workforce, and access. I think those are the 5 key concepts at least. Why are indicators important? After the very first Lancet Commission meeting, we finished and had a great day. It was that picture that I showed you with Anna. An environmental economist came up to me and he said, "You need to focus on the World Development Indicators." And at that point, I said, "I don't even know what those are. What are you talking about?" So the World Bank has the WDI section. They collect indicators on everything you can imagine, not just health, all right? Roads, education, you name it, they have data on it. And I said, why? Why is that so important? And he said, well, in the environmental economics world, 30 years ago, we had no data in the WDIs. And as we started to get data into the World Bank, what we found was that people started to use it, make conclusions from it, get their PhDs based on it, and it was actionable data. And so that will change your ability to advocate and change policy. And he was absolutely right. So we worked on that, and by 2018, you can see this is the Atlas of the Sustainable Development Goals. So this is published by the World Bank. And by 2018, they were publishing surgical workforce data. Again, a first ever for the World Bank. I mean, prior to, I would say, 2015, you probably could not have found the word surgery in a World Bank publication. By 2020, again, in the same atlas, they were publishing the impoverishment data and the surgical workforce data. All right, so this is, I think, deceptively important. Now the World Bank is paying attention to things related to access to surgical care. Even more importantly is when you have countries and regions that work together. So this is in the Pacific region. These are leaders in many of the Pacific islands. They came together, and don't look at all the data, that's dizzying, but indicator 1, 2, 3, 4, that's 5 and 6. What they did is they came together, they collected data on the Lancet indicators together in each of their Pacific Island countries. And more importantly, they started to compare them with each other, openly and transparently. So they were willing to say, well, here's my 2-hour access, here's Tonga's. all right? And they compared it to other papers that were out there, other data that was available. Here's my surgical procedure data, and they took this to their ministries of health and said, look, we are so far below 5,000. You know, Tonga's doing okay. You know, we want to be able to do better. So there's a little bit of internal competition. And at least visibility. It then allowed them, as I say, to go to their ministries of health and say, here's where we fall. All right, so that's indicators. Now, this is the last thing that came out of the Lancet Commission, this concept of National Surgical Strategic Planning. And again, that's not my painting, that's ChatGPT. So I want to talk about Emmanuel Macasa, and Anna's probably heard me tell this story more than 5 or 6 times, but in the Lancet Commission, we were talking about the concept of national strategic planning, that countries should have a strategy for surgery incorporated into their broader national health plan, because no countries had a holistic surgical plan as part of their national health plan. So we were at I think our second to the last meeting in Italy, and we were at a long table, and I was at one end, and Emmanuel Macasa, he was the Zambian delegate to the WHO, and we talked about the concept of national surgical strategic planning. And then we went on and we were talking about other things, and all of a sudden, Emmanuel's just holding his hand up like this. He didn't say anything, and I saw him, and I said, well, please, Emmanuel, please, go ahead. And he said, I have just been texting my government. We will be the first country that creates a national surgical plan with the Lancet Commission. I was a little taken back by that, and the only thing I could think to say was, geez, I wish I could text my government. Which is unfortunately very true these days. Now that was interesting. So it's an interesting comment on leadership. And just watch what happened in Africa. So Zambia did that, and then Tanzania said, hey, wait, we can do that. And so they went through this process, an elaborate process, bringing stakeholders together, having a workshop, drilling it down, having a much smaller working group that's going to really write this document, and then taking it to the Ministry of Finance, costing it, and then passing it into law. And so they went through that. And then this is Permanent Secretary Mpoki, and he's giving his plan to one of the other permanent secretaries in the SADC region, the Southern African Development Community. And I said to him, why are you giving your plan to these other countries? They can't even use it, you know? And he said, you know, there's competition amongst us. He said, when they see what we've done, I think they're going to want to do something similar. And so then Zimbabwe. And then the whole SADC region. So I think in 2018 or 2019, the SADC health ministers passed a resolution that all SADC countries had to have a national surgical obstetric and anesthesia plan. And then it grew outside of the SADC region. So now more countries in Africa are talking about this. And then once that happens, then you start to get the attention of someone whose attention you want.
Professor John Meara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen. Greetings from Geneva, and thank you for the invitation to speak to you today, and I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical
Think
services.
about what he's saying there. Where does that come
9
from?
of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world.
When he says 5 billion people, that just never gets old. Like, just the fact that he is willing to do that. And every point that he's making, you have to understand behind that was research and a research group that brought that laser-focused data point to him, all right? So and he goes on for 5 minutes and brings up, you know, a number of things from the Lancet Commission and other places. And one of the main points is that all of that came from somewhere, and it was research-based. Now, after he took a verbal and visible position on this, the other regional offices, so the WHO has 6 regional offices, the Western Pacific Regional Office started to pay attention, in concert with the fact that they had countries in the Pacific Islands who were doing the work that I was talking about. So it was all beginning to be synergistic. And in 2020, it's called the WIPRA, Western Pacific Regional Office, they passed their own resolution. So regional offices can pass resolutions in the way that headquarters does in Geneva. And so they passed this resolution, which is essentially calling for countries to have a surgical plan that's integrated into their national health plan. All right, and so I'm trying to show the arc of what happened with data going to Tedros, countries picking this up, ministries of health picking this up, regional offices of WHO starting to pick this up. And then it left those regions. So this is Ecuador. This is Alfredo Barrero. He's a neurosurgeon. He was vice president of Ecuador. And his aide called my office, and my secretary said, there's someone from Ecuador here. And I talked to the aide, and he said, Vice President Barrero has seen what's going on, and he wants to have a surgical strategic plan as part of his healthcare plan in Ecuador. And so he got that across the finish line. It was just passed in the fall. It's part of law. You know, unfortunately, his party didn't win, so he's out of government right now, but it's in law. And he actually wants, in his post-vice presidential term, he wants to galvanize Latin America and do what's the same thing that's happened in the SADC region and then the Pacific Island region. So you see the trajectory of this. More countries, I need to move this map over now and show Latin America. So that's where I've seen global surgery going in the last 10 years, and now I want to talk a little bit about what I see in the future. And this is really a haunting ChatGPT image. I asked it to demonstrate something related to global surgery, climate change, pandemics, and forced human migration. So I think when we look forward to surgery, we need to concentrate on these things. So we can't create national surgical plans for the 20th century. All right, in the 21st century, there are some things that we weren't thinking about maybe in the last century, and one is climate change. Amazing, healthcare is responsible for about 5% of the global greenhouse gases. The operating theaters that we work in, 6 times more energy intensive than the rest of the hospital. If you just added up the operating rooms in US, Canada, UK, that's the equivalent of 2 million gas-powered cars per year, just for those 3 countries. And some of our supply chain, so what are we using in the operating room? Desflurane, for example, 2,000 times the heat trapping capability of CO2. So we need to look at what are we doing in theater, and how can we be smarter? And then there's this vicious cycle that the current surgical care both contributes to climate change, and climate change contributes to changes in surgical disease that we have to deal with. So it's, as I say, it's this vicious circle, and we're kind of creating our own problem to a degree. And the last video, I want to show you what Tedros has to say about this.
Dear colleagues and friends, unprecedented flooding in Pakistan, drought in Africa and Asia, fires in Europe. We live in a time of multiple overlapping and related crises. And many of the victims of this crisis need surgical care.
Multiple overlapping and related crises. And that's why I think these 3 are important, because they are not distinct from each other. The next is pandemics. I'm not going to speak a whole lot about that because we've all lived through that and we all know. And so instead, I'm going to ask you some questions. How did COVID affect surgical care delivery? All right. How did surgery respond to COVID? Many of us became frontline COVID providers. right? So what's the relationship between surgical care, workforce, supply chain, infrastructure, et cetera, on pandemic preparedness? There's definitely one there. I don't hear it being talked about enough. I saw this recently, and I saw that the IMF feels that the COVID cost was about $12 trillion, okay? And then I saw that they estimate this many people died, and then I saw they talked about the number of people that were pushed into poverty, and I thought, gosh, those numbers sound roughly familiar. And I looked at the numbers that came out of our work and what they're talking about COVID, and it's always precarious to compare things like this, and I'm not in any way trying to say that one human tragedy is worse than another or more important than another. But I think it's enough to say these are huge human tragedies, and they are related to each other. As I said, how did COVID affect surgery? How did surgery respond to COVID? And I guess my main point is we ought to at least be linking these two in our discussion, and particularly when something like this comes out, a $500 million funding round for pandemic preparedness. Are we there? Are we at the table? There's that famous saying that if you're not at the table, you're probably on the menu. Are we there explaining with data why surgery is important for pandemic preparedness? And then the last on forced human migration, and I think this is not being talked about enough in surgical strategy. You look at the data around this, 110 million people displaced, 35 million refugees displaced across borders, all right? Almost every country is being impacted by this, all right? And so my point is that surgical planning cannot be made in sovereign isolation. You can't create a surgical plan just looking at your population saying, okay, we have 36 million people, that's what our plan's going to look like. Because this is affecting everyone. And I did a quick search to see what in the academic world on migration, what's going on. There are dozens of papers on migration, but I haven't seen much on how does surgery contribute to that? How do we address that issue? How are countries planning for that? When we're making our national health plans at a national level, how are we incorporating the surgical realities and the forced migration realities? And so this is my second or third to last slide. This is one of my other favorite quotes of Paul's. With rare exceptions, all of your most important achievements on this planet will come from working with others, in a word, partnership. And I asked ChatGPT to make a surrealistic image of Paul Farmer incorporating the concepts of partnership and accompaniment. That's all I told it. This could not be closer to Paul. He would have loved it. I'm disappointed that he can't see that because it captures him so well. And so in summary, I want to highlight 3 issues. First, the concept of accompaniment. As I said, Paul could hardly go through a sentence without talking about accompaniment, and I think we need to think about that in what we do, and also at a national level. Richard Haas talked about sovereign obligation. It's kind of an odd 2 words to put together. People don't normally talk about sovereign obligation. So accompaniment works at all levels. 2, the academy. And what I tried to show you is that everything along the way was based on academic work on the academy. And even when it got to the point of advocacy, and the reason I showed you some of those videos is they were saying things that came from research groups that had been working behind the scenes for months to bring something forward that then became advocacy, that then Tedros was willing to talk about, that hopefully will change policy. So the academy is hugely important in these types of things. There is no good advocacy without research. And then the point I already made, which is when you think about global surgery strategy, what does a global surgery strategy need for the 21st century? Let's not make the best surgical strategy for the 20th century. And so this is my last slide, and I'll let you think about that for a moment. Go from left to right. Who are blue fish and who are red fish? And when you go from the first image to the second, what's happened to the blue and red fish? And when you go from the second to the third, why are the blue fish doing that? And then in the fourth, what's happened? What's different about the fourth image than the first? This is somewhat a summary of my talk and a summary of Paul's philosophy and the impact that he had on me, at least, and the way I look at global health. So thank you very much.
Wow, fantastic, inspiring talk, and I think we do have time for a few questions if there are any.
Thank you so much, Dr. Meara, for that presentation. So my name is Asad Naveed, and I'm a postdoctoral fellow in trauma at St. Mike's Hospital. And I studied medicine in Sierra Leone, and coincidentally, when you visited Sierra Leone, I was in that meeting. I was the, I was the president of the Medical Students Association then, and I was representing them in the meeting. And what you said completely resonated with me. In fact, there was an Ebola outbreak during that time. So when you brought pandemic and its connection with surgery, it resonates with me so well. Thank you so much for your presentation, and I'm very impressed with the progress that has happened afterwards. My question is a very practical one. So in Sierra Leone, because there are very few surgeons and it takes time to train surgeons, there's a Dutch organization called Kappa Care, which is training CHOs, community health workers, to do emergency surgical procedures. And there's something similar happening in Kenya as well. What is your view about training CHOs, which are equivalent of physician assistants, to do surgery?
Yeah, so the concept you're talking about is task shifting, task sharing. And we wrestled with that in the Lancet Commission. It is a reality in most countries. There are some issues in some countries, but it is certainly a reality. We're dealing with that in the US. We have PAs, physician's assistant, and nurse practitioners that are becoming, that are taking on this role. So I think it's absolutely what's needed, and you can bend the cost curve, so to speak. I've done some costing work with a professor named Bob Kaplan at Harvard Business School, and one of the things that he tells us in our costing work is that you need to get everyone operating at the top of their license. So if you have these folks who can do certain things, absolutely I would recommend that. I think the question is, how do you create a community for them, oversight for them? And I think the interesting thing will be, is there a way that technology can advance what they can do in a safe way? And even at dinner last night, we were talking about, in a rural area, someone needed a burr hole, but there was not a neurosurgeon up there. So are there ways that you can provide safe oversight? Because you don't want task sharing and task shifting to mean it's poorer care for people. So I think you still need to uphold the quality of the care that you're delivering, but it absolutely is part of the equation.
One other question, if there's no one else waiting. So with AI becoming popular, do you think AI has a role in global surgery?
It's certainly good at making pictures about global surgery. There's no question about that. Yeah, there's no question, and it's frightening to think of where it's going to go. But there's absolutely no question that's going to be play a huge role in this. No one would deny that. I think, in fact, it's probably a matter of just controlling it and making sure that we have the proper oversight over what AI does with us and for us and hopefully not to us.
Thank you so much again.
I think that we'll maybe continue discussion over lunch, which is outside. And so lunch will continue until around 12:30, and then we'll have our second e-poster session from 12:30 to 1:30, and then we'll reconvene here at 1:30 for our symposium on global surgery.
Excellent.